Welcome to Heartland Rehab Podcast, and today we're talking about total hip replacements, a surgery that over 800,000 people undergo every year in the US alone, and of course, millions more worldwide. And yet most of us have very little idea what it actually involves until someone we love is facing it. And joining us today, we have Dr. Lim Chin Tat, a senior consultant orthopedic surgeon specializing in complex joint replacement and sports surgery at Orthopedic Practice and Surgery. Dr. Lim trained at both Oxford and Stanford and has published over 30 peer-reviewed research articles. And as always, joining us is Bala, co-founder of Heartland Rehab, and with over 10 years of experience in musculoskeletal physiotherapy, bringing the rehabilitation and long-term recovery lens to everything we discuss today. All right, so thanks for joining us today, Dr. Lim. Could you tell me a little bit more about yourself? What's your journey into orthopedics, and why do you specifically choose to be an ortho compared to so many other variety of medicine subspecialties?
Thanks, Aaron, for having me here. So, after we graduated from medical school, we first and foremost, we wanted to be the doctors to help patients, to help people. And then what brings me to orthopedics, that's interesting because I've been a soccer fan.
Oh, you've been a soccer
Yes,
fan?
I've been a soccer for many, many years. I think since secondary school, upper primary school, I started watching soccer. And in soccer, there's a lot of injuries.
Yes.
Knee injuries, ankle injuries, and I'm a Newcastle fan. So my greatest hero is Alan Shearer. Okay, maybe different generation. Okay, so Alan Shearer. Okay, it's okay. But he suffered a few serious injury. I mean, he have an ACL tear, anterior cruciate ligament tear. Okay, he has ankle dislocation. Okay, but he did recover from the injuries and did pretty well after that. So a lot of joints involvement, a lot of bony injuries. Yeah. So that is maybe my first exposure to orthopedic.
Right. So you were inspired by him, or you were inspired by that before you became a doctor, or after you became a doctor?
I was inspired by him to be a soccer player. But obviously I didn't make it. Okay, obviously I didn't make it. So after I became a doctor, when I was choosing a field to specialize in, I mean that definitely played a role in influencing me to choose orthopedic.
Right. Because you have seen, I guess, someone that inspired you when you were younger, how he got injured and how he recovered, right?
Yes, exactly. I mean, we follow his recovery process. I mean, the news. I mean, English Premier League, is a big thing. So I think he was out for almost a season.
Was one full season?
Yeah. And Bala will know, right? ACL tear is easily one season.
Takes a while to recover. Even in elite
9 months?
Elite levels, you can possibly get back faster, and they take on some risk as well, but they see the physio I think 3 times a day.
Yeah.
Okay,
for those professional players, it's really 3 times a day.
Yeah.
It's really 3 times a day. And it still takes about 1 season out. Yeah.
Oh, that's...
So basically answering your question, that really is a big influence. Okay. Right. And then I choose orthopedic, and I even choose to be a hip and knee specialist.
Yeah.
Because that's the most injury, the soccer players have. Yeah.
Right. What's, I guess, the most complicated surgery that you've ever done?
So the most complicated surgery I've done is when I was overseas. So when I was overseas training. So we did a lot in Singapore. A lot of the specialists did overseas attachment to fine tune the skill, to increase the exposure. We will go to high volume center. I mean, I've been to Oxford Hospital, Oxford University Hospital, as well as Stanford University Hospital, to participate in the surgery and then to learn. Okay, so we do a lot of revision surgery there. So it's a tertiary, example in Stanford, it's a tertiary center. So it's a place where all the complicated cases from the other part of the state or the other part of the America will go and look for treatment. So a lot of them have failed. I mean, the surgery have failed. Example, a hip replacement. They did a primary hip replacement, it loosened or it got infected, and then they look for a hip specialist. So they will come to Stanford and then we will do the surgery. So many of the cases there will be removing the hip implant, cleaning up the hip, closing up, and treat them with antibiotic, and then going in again.
Round two,
or sometimes even round 3 or round 4. So in Stanford, we see a lot of all this. Okay, it's actually a dedicated hip center.
Oh wow. Okay. I'm So we don't have too much of that in Singapore.
Touch wood, yes.
Yeah,
We don't
okay,
have too much.
That's good.
And is that generally like a long wait for this kind of patients in America to come in to see the hip specialist?
Yes, it's a long wait to see the. Sometimes they will fly back to their home again and then fly in for the surgery. So it's a long waiting time.
Okay.
But they do want to get the hip specialist to do the surgery.
Yes, especially if it's a revision.
Yes.
And what's the main difference between, I guess you were saying it's more prevalent in America or other countries. What's the difference in Singapore that makes it less likely?
So we do know that in Singapore, in the Asian context, the hip, our population tends to get less of a hip issue. We see a lot of knee issue, right, Balara? We see a lot more knee issues. I mean, there could be certain factors involved. Example, femoral acetabular impingement. You know, the carb and the cam lesion is not so common in local context, local population. So it's a condition where the hip joint, so the hip joint is actually a bow and a rounded spherical head. So it's supposed to articulate nicely, okay? So in a patient with femoral acetabular impingement, either the bow is a bit tilted, so it causes impingement, or the head itself is less spherical. So maybe there's a bump here. So when they move, there's a less room or there's a higher chance for them to come into contact with each other.
All right.
So that creates a lot of stress when they articulate.
And you find that this generally happens for non-Asian?
Yes, in the Caucasian population. I mean, studies have shown it's proven that it's more common in them.
Yes.
And also, if I may say, they are also more sporty. And there's college sports plays a big role in the States. So they tend to squat a lot more. I mean, in sports, we tend to squat a lot more. So it tends to have a lot of issues in there.
Yes.
Yeah, so a lot of impingement. So that's one thing why there tends to be more hip issue there.
I see.
Then what about Singapore? What are the most common hip conditions that you see in Singapore?
I mean, in Singapore, we do see hip osteoarthritis, wear and tear. I mean, with the aging population, definitely we do see a group of patients with wear and tear, degenerative hip condition. Okay, and also again, we are definitely the population is getting more active. We are doing more exercise, and then the government has played a good role in pushing people to exercise. I mean, in Straits Times, I read an article to advocate to encourage 150 minutes of moderate exercise a week.
Yeah.
So I think the people are exercising more.
Yes.
So then there'll be more wear and tear. I mean, hip osteoarthritis is one of them in the aging population. In the younger population, they do have a labral tear. The labral is the outer covering of the hip joint. So in the bow, the main part is bony, but at the edge, we have what we call a labrum. Okay, and that could be torn when the patient squat and there's a impingement and there's a contact.
So when it's too much pressure, then that
Too much
little
pressure.
lip could be broken.
Yes, correct.
That's interesting. So you mentioned, I guess, hip OA, and you mentioned wear and tear, and you also linked it up with exercise. Now, from my understanding, I heard that exercise is supposed to prevent osteoarthritis, but you mentioned that people are doing more exercise and they're having more osteoarthritis. So that, I guess, just goes against what I've been reading up online. Can you just elaborate a little bit more on that?
Wow, that's a good question. Every patient asks this question. I don't know whether you get that question.
Yes.
Yeah.
Should I exercise or not? You know.
Is it a good thing or is it a bad thing?
So I would say definitively exercise is the best prescription. Okay, exercise is the best medicine. Okay, exercise is good, but it's all about moderation and conditioning, right? It's whether your body is tuned in to exercise the way you want it to exercise. Right. Exercise, I would say exercise is only good. Exercise is good for weight management. Exercise is good in the sense that it tightens up the muscle, it strengthens the muscle, condition the muscle to allow the joint to articulate in a smoother, so there's less friction. Okay, so and exercise is also good for mental health, I'm sure. Okay, but otherwise, your take on this exercise?
Yeah, like you said, I think exercise is generally good, and it helps to lubricate the joints and get the joints moving, get the muscles strong, so there's lesser stress onto the actual passive structures like the joints, the labrum, and so on. But like what Dr. Lim said, I think moderation needs to play a part, and especially these days, like I don't know whether it's the government's movement towards it, but we are getting more into these high intensity sports like high rocks, like now BFT, Revel, all these things are blowing up everywhere. Whereby I find that people may not be conditioned to take part.
Correct. That's what, exactly. So I always tell my patients it's a gradual increase in intensity and frequency. Okay, and if you cannot manage, sometimes it's about conditioning. So it's about conditioning yourself to be able to adapt to the exercise you want to do.
Right. Okay. So just to make sure I get it clear. So it is not the act of exercising that causes injury, but is to a certain extent overuse. Right. So if we're doing something beyond our abilities and we're pushing too hard, then that can cause injury. But exercise as a whole is definitively good for you.
Yes.
In fact, it can probably help prevent OA as well, but when done in moderation. And I think that's where just now Bala mentioned you got to build up, and you talked about high intensity exercise. I guess it also kind of depends, right? What is considered like a high intensity exercise? Maybe we could dive a little bit deeper into that, because I think for different people that definition may change. So what's like a universal principle someone may use? For example, myself, I just did high rocks last year. I don't think that made
hips are good.
Anything worse. I think my hips are good. So I will think that to me that isn't too much of that too high intensity. But again, that's me. If I were to compare it to let's say someone in their 50s, maybe 60s, then I think that's extremely high in terms of intensity. So what's like a good like gauge that someone can use? Like, hey, maybe I'm pushing myself too hard. Maybe I should like slow it down. Maybe running 10 km on my very first run in 5 years isn't too good. Maybe I should start with 1. But what's that range, and how do I roughly like gauge myself?
Okay, with regards to exercise and progression, so I think we have to take it week by week. So you want to start off at a normal baseline and see whether you complete it and you are not injured. You are still able to walk the next day. Even for myself, like I just recently switched from going to Anytime Fitness for just weightlifting and changed to high intensity exercise group class, which again motivates me and pushes me. But I also find myself that I take a bit longer to recover because it is of a higher intensity. So I can't go like I'm trying or back-to-back sessions. But many people, because many of these places, they also tie you in with weekly packages and all that. So you're kind of incentivized to work out as hard and sometimes even multiple times a day. I know people do that, which again, coming back to the topic of progressive training, you need to give yourself some room and time to recover from your high intensity exercises, and nutrition, sleep, and all these like basic things needs to play a pivotal part. So I think those are the missing components to progressive training.
Yeah. Okay, so it's not just slowing down your training, but it's also just listening to your body. Like if we're going for something high intensity, if you feel you're aching a little bit and you feel very tired the next day, maybe take it slow. Maybe give yourself a couple more days of rest.
Yes.
Then when you feel that you're fully recovered, then maybe you can take it up a small notch.
Yes.
If you were to give like a number, would it be like 10%, 15%? Like, hey, if I feel like I've pushed myself really hard. I did like maybe 100 kg squats, like 100 reps, something insane. And then I'm aching for like a week or maybe 2 weeks. When I feel like I'm recovered, when I'm going back to it, can I like double my load? Is that not a good measure to take? Or maybe like, just a 5 to 10% increase the next time. Is there a number, like a rule of thumb that someone can use?
Yeah, I think a good rule of thumb or like a metric to use is your RPE, so rate of perceived exertion. So when you were doing the 100 kg squat, for example, right? So how difficult did it feel? So if you are saying that, it felt 5 to 6, and then you are coming back from, let's say, injury or recovering from it, you don't want to go back to 100 kg feeling 5 to 6. You want to go back to lowering it maybe 10 to 20%. So maybe trying a 80 kg weight and see how that feels. Does it feel like a 5 to 6, or is it 7 to 8, means you're overdoing it, and you cut back the load? Or if it feels too easy, then you know you're ready to go back to maybe previous levels, because our muscles, contrary to popular belief, it doesn't waste away as fast as we think it does. So there are studies to show that muscle strength and gains, they tend to maintain for a longer duration than we think. So it's okay to take a break and come back into the groove of things.
Okay. Just now you mentioned RPE. Could you just elaborate a little bit more on that? What is RPE, and how does that measure out?
Yeah, so it's quite closely related to, we still use heart rate, but it's more for aerobic capacity. So for strength training, I think RPE is a better measure, whereby the lower end of the scale, it's easy minimum load, whereby when you're going to the 4 to 6, it's moderate intensity. And if you're doing anything between 6 to 9, it's quite high, and you don't want to be at a 10 for sure. 10 is your 1 RM, your 1 rep max.
Okay.
Yeah, so that's how you can quantify.
That's a good gauge, right? So at a 10. Also RPE, just make sure I'm right. It means perceived
Rate of perceived exertion. Yes.
Okay. So if 0 is I'm doing absolutely nothing.
Yep.
I'm chilling, and 10 is I can only do 1 rep max. Then where do I lie in between that? And pushing myself maybe to a 5 or a 6 is a decent level, but consistently pushing myself to a 9, maybe day after day after day, is probably not the best.
Yes.
Okay, thanks so much for that. I think that also helps me and also helps other people watching have a sense of, okay, how can I gauge myself, and just to ensure that I'm not progressing too hard, too fast, or too slow and having no growth at all.
Yes.
See, thanks so much for that. I think coming back, let's just imagine that I am someone who is having knee pain. I don't know, maybe I have hip OA. Maybe I've torn something, I'm not sure. But I just have this tremendous hip pain. I have trouble squatting, standing also hurts a lot. What should I do at this stage? Let's assume that I am someone in their 40s, for example. And what should I do? Should I go see a physio? Should I straight away go and see a specialist? What should I do in this case? Maybe Dr. Lim, you can advise me on this.
I think first and foremost, whether there's a trigger. I think the first thing I will try to identify is a trigger. Whether was it related to an injury, whether it's related to a fall, or whether the pain just start just after exercise. Sometimes it can be delayed onset muscle soreness, but sometimes it can be something serious. Let's say it's an injury related one, I would definitely suggest seeking medical help. Okay, because we really don't know whether it could be a stress fracture, a labral tear, or just muscle pain. Okay, I mean, if the patient do see me, definitely we'll take a detailed history. Okay, to check for triggering, to check the type of pain as well, whether is it rest pain or whether is it mechanical pain. I mean, rest pain is the pain that is always present, even when you're resting, when you're sleeping. This type of pain is really tricky in the sense that it could be due to infection or cancer. Okay, and it's not common in 40 plus, but we definitely don't want to know that it's a rest pain. If it's a mechanical pain, most of the time is on movement, on loading, and that could be due to the muscle, the cartilage, or the ligament. Okay, then we will examine the patient, and during the examination, you will give us an idea what is the problem. We can do the anterior impingement, posterior impingement test to check for labral tear. We can check the range of movement. We can also identify the source of the pain in certain sense. Because sometimes the pain can be referred pain, right? I mean, it can be referred from the spine. So it may not be from the hip pain causing hip pain, it may be from other area. Yeah, so that's something that we need to see the patient to make sure it is not, it is exactly in the hip joint.
That sounds like it could be quite complicated, right? And from what I'm hearing as well, if it does stem from, let's say, a particular injury, I should most likely just get it checked out. Is that what I should do?
Yeah.
Okay.
And then, I've seen many patients who will try to self-medicate, rest. I mean, there's nothing wrong with that. I'm quite active. I also get knee pain, hip pain at times. Okay, so sometimes I will just rest, change my exercise regime, ice it, and wait for a few days. But if the pain persists, I think it's time to seek medical attention. Or if it's rest pain, then there's more urgency. Let's say pain that wake you up at night.
Okay, so let's say I fell and I got injured. And it's been a month or maybe 2 months. At what point should I be like, hey, this is taking way too long. I should probably get it checked out. Is it 1 day, 1 week, or maybe 1 year?
I think for a younger individual, maybe 2 weeks is reasonable. But let's say example is 70 or 80s, then I think it should be like 1 or 2 days, because in that situation, I'll be worried of fracture. Okay, but if it's a young, active guy who can still walk and still weight bear, I think waiting 1 to 2 weeks is perfectly fine. But if you cannot weight bear, that means you put your weight on it and there's really acute pain, I think you should seek medical treatment even earlier.
Okay, so it's not just the time aspect alone, but it's also the type of pain that we feel. If we're standing up and just putting a weight on it causes tremendous pain, we should probably get it checked out as well. Maybe for a young person, you can wait maybe for like a couple of days to a week. But for someone elderly, we should advise them to seek medical attention because there could be potentially a fracture, and we want to get that sorted as soon as possible. Right, just now when I mentioned as soon as possible, so your eyes just light up a little bit. If we wait too long, let's say you do have a fracture
Yes.
and we don't get it treated for maybe it's like 2-3 weeks. Will something bad happen?
There could be displacement of the fracture. So if we detect the fracture early, we could advise the patient accordingly. That means non-weight bear, wheelchair, use a walking frame and offload the leg. So that even if there's a fracture, it doesn't displace. So if it doesn't displace, allow the fracture to heal, and that would avoid a surgery.
Oh,
Yeah.
so actually completely avoid a surgery.
Possible, but if let's say there's a displacement, then we would need to do a surgery.
Okay, so I think from hearing that, making sure that we do seek medical attention as soon as possible can actually help us, can you save a lot of pain
Yes.
and time.
Just to add to this point, right? So I have a experience with one of my clients. So she's an elite runner. So runs like multiple marathons, running is life, right? So came to see me for hip pain. So at the start we were thinking it's more like a adductor tendinopathy, where it's a strain of the tendon because a lot of high intensity running, ramping up towards the marathons. But I did advise, say, like if it's not getting better and you shouldn't be in this much pain at this point in time, which is what you call like a red flag, you should go to the doctor and get it checked. And true enough, she went to have it checked, and usually they are a little bit more reluctant to getting a doctor's eyes into what, it's just fear of knowing what it is. But she eventually it got more and more painful and found out she had a pubic symphysis fracture, not from a fall or anything, just from running.
Wow, okay.
Yeah. And of course, after that, she needed quite a prolonged duration of rest, and now she's back running again. So, but you do need, like what Dr. Lim said, get it checked, right? Because I have seen many cases where they have fractures, but they're still able to walk, and they always tell me, say, bro, I don't think it's a fracture, I can walk, right? Then I always tell them all these scenarios, like this other guy came in, could walk, but turns out the X-ray didn't catch it, had to do an MRI to see. Yeah. And all you need is a period of rest and you're back at it, rather than always be thinking, oh, what's wrong? Yeah.
Oh, that's actually pretty interesting. I didn't know someone could actually get some sort of fracture just from running. Like, that's not something that I would expect.
That's really interesting because now you reminded me I have a patient, an army boy.
Boy.
So first started, got enlisted, doing a lot of training, a lot of loading. So developed hip pain. So I did an X-ray. There's no fracture. But the pain persists, so it came back to me very soon. So I decided to do an MRI scan. Oh my gosh, it's a stress fracture. The hip stress fracture. So I have to put in on non-weight bear for 6 weeks for the fracture to heal. So it's a stress fracture, so it's an impending fracture. It won't be shown on the X-ray.
Yeah.
But when you do the MRI scan, you can see all the edema in the femoral neck. So there's already some signs of fracture. Okay, so if he persists with the training, it will break.
For sure.
Yeah, in a fracture in a young man is disaster.
Yeah.
So I offload him, I excuse all training, and eventually that's it. He recovered from that. So early detection is important. That could have changed his life.
Yeah. Okay, so from hearing all of this, now I feel that, okay, if I feel anything, I'm just going to get it checked out.
I have clients who text me and say, hey bro, like I did this and this hurts and these are my symptoms. And I'd be like, oh, can I book a session with you? I'm like, no, you should go see a doctor. Like, this is a bit more serious. And they're like, no, can you just like look at it and tell me? Say, for sure, the money that you spend seeing a physio, it's not as worthwhile as going to see a doctor and getting the scan done. But sometimes you just need that scan to let you know if it's not a fracture. Great news, I can see you all day and get you sorted. But if it is, then you need other interventions.
Yeah. Okay. So it's good to know that about getting the early intervention or just getting like some early screening as well. But let's move backwards first. So a little bit before that, let's talk about like hip preservation. So I know it's a bit specific because it's like hip, but I guess it kind of applies generally. But how can I prevent myself from getting injured, prevent myself from getting degeneration? Like you mentioned, wear and tear, you mentioned people falling, and sometimes you have these like stress fractures, although that was more on like the tights as well. How can I prevent that? What are some good measures that I can do?
Weight management, I think one of the most important prevention for all the joints is to maintain a healthy weight. Okay, because that will reduce the loading over the joint. Smoking, I think smoking is a risk factor for osteoarthritis. Alcohol, overuse or overconsumption of alcohol can cause a condition called avascular necrosis of the femoral head.
Oh,
so
that is when there's no blood flowing towards the hip,
exactly,
right?
yeah. So that, and then the femoral head will collapse. So instead of being spherical, it collapsed. So it loses its spherical shape. So the articulation is not so good, and then it causes wear and tear. Okay, so that's
alcohol. Like
alcohol,
overconsumption of
overconsumption of alcohol. Yeah.
What is over? Asking for a friend.
Yeah.
Okay, I think there's a certain numbers, but I really cannot recall the number.
But generally, don't drink too much and don't drink too often as well.
Yes.
Smoking
Yeah.
and weight management. And I
Yes.
think we mentioned exercise.
Exercise is important. Exercise is important. Yeah.
So if someone were to generally stay lean, exercise a lot, they don't drink, they don't smoke. Generally, they don't tend to have too much hip problems, just based on your experiences.
Yes.
So most of the clients that you see generally belong to one of these few categories.
Most of my patients, I don't see them as clients.
Oh, patients.
Just joking. Yeah. So hip problem, but it's not very common in the local context actually.
Because you mentioned that most of the time, locally, we tend to get more knee injuries, right? I'm just curious, even though we're talking about the hips today, I just want to ask a little bit more about the knee as well. From your practice, what's the ratio like? How many knee versus hips do you normally get?
I would say maybe 20 to 1.
20 to 1? Oh, well, I thought it would be like maybe 5 to 1 or
No,
like
the knee
3 to
problem
1.
is really a predominant. We are not talking about surgery, we're just talking about patients that come in with complaint of knee pain. I think knee pain is really a lot more.
But can I ask, biomechanically, does the hip relate to the knee? And does it increase, let's say even for people getting more wear and tear, if their hip joint is structured or like put in a certain position, that can either affect the hip or further down in the knees itself?
I think the two joints are definitely related. I think all the joints are related. So when my patients get pain or restriction or stiffness in one joint, it always affect the other joint because the other joint will always compensate to maintain the normal gait. Example, just a gait, right? So example, if your knee is stiff, your hip tends to move more to compensate to overcome the stiffness, to increase the range so that you can still walk normally. And the hip joint and the knee joint is linked in a certain sense that there's a nerve that supply both joints. So sometimes when you get hip pain, you actually present as knee pain. So this is the referred pain that we mentioned earlier.
Could you just elaborate a little bit more about this referred pain? Because just now you mentioned like the spine, and you say hip pain, and now hip and the knee. So it sounds like you can still feel pain on a certain joint, even though there is nothing wrong with it.
Because the sensory supply for these joints come from maybe a single source. So they cannot differentiate where is the pain at certain times.
So like could you elaborate a bit more on that as well? Like you say single source. So there is like one major nerve that runs through the hip to the knees, and that's what's triggering the pain.
Yes, so one of the branch of the nerve that actually supply the inner side of the knee, and that nerve also supply the hip joint. So when there's an inflammation in the hip joint, it triggers off the pain sensation, but the body can't tell what is it from the hip or the knee. So that's why it's important to examine the patient sometimes.
Right, and again, I guess that also leads back to, hey, if you're having pain, you should get it checked out. All right, cool. So we've talked a little bit about how we can preserve our hips, a little bit of our joints as well, and then when we should get it checked out. Now let's move and say, hey, maybe I'm someone in my 50s to 60s. I'm someone who hasn't been exercising for the majority of my life. Maybe I'm a little bit overweight as well, and now I'm feeling extreme hip pain. I got it scanned. I have something called osteoarthritis, and it's really, really bad. What would happen at that point of time?
I think so. First and foremost is to understand the patient expectation. So what kind of lifestyle they are leading? Are they very active? Do they like to travel? And how much is this pain affecting their quality of life? So we treat every patient differently. Some patients are more sedentary, so their expectation and demand is lower. But I have many patients in 50s, 60s, they're traveling, enjoying life, going from country to country, or people who are running marathon, half marathon, 50, 60. So for those patients, I treat them, may I say, a bit more aggressively to get it back to the lifestyle that they want. Okay, so there's many treatments. I mean, the first line treatment, of course, is physiotherapy. I always send my patient for physiotherapy because I feel that it's the intervention that's good pre-op. If they need op, doing physiotherapy is good. Okay, it will help them in the recovery process. If they are not going for operation, then physiotherapy will be a mainstay treatment because physiotherapy actually empower them. unlike other modality of treatment, physiotherapy, I feel that teaches them what to do. They can do it themselves at home. They don't need to come every day. and it teaches them how to take care of themselves. So physiotherapy is essential. I routinely give them some anti-inflammatory medication to help them control the inflammation. So it also makes the physio process a bit easier with less pain. Sure. Okay, so these are the first line treatment. If that fails, sometimes we consider injection, like a steroid injection. Steroid is a very powerful anti-inflammatory medication, and instead of taking orally, we go straight to the joint. So we can inject a high concentration of steroid into the joint rather than than oral consumption, which will have other side effects. So that will reduce the inflammation, and then the pain may go down, and then they go for physiotherapy, and then we see how it goes. But if that doesn't work, sometimes we have to do surgery, and of course for hip, it's a hip replacement surgery.
Right. Okay. So there's a few levels here. One is you just do physio, and second one we can do some injections.
Yes.
And then the third level is when probably surgery. But where do you draw that line? I think you kind of talked a little bit about it. It kind of depends on the individual as well.
Yes.
So if someone is looking to stay active, would they just go for physiotherapy or injections, or would they be leaning more towards surgery?
Okay. I would say physiotherapy and oral medication is the first line. So I would definitely get them to try that first. If the arthritis is very bad, I may skip the injection totally, because I think the yield from injection may not be high.
Right.
And injection is not risk free, because injection is there's still a low risk of infection when we do injection.
Yeah.
Okay. And if it's not likely to work, I would just skip the treatment and go straight to surgery. And when I offer surgery is if physiotherapy fails, if medication fail, and if the pain is really causes a drastic change in the lifestyle of the patient. Right. And of course, they must be fit enough for surgery. Okay. Surgery is always a balance between the risk and the benefit.
Right. Because it's not just like a simple just removing and replacing. There's a lot of consequences.
Yeah, there's a lot.
Yeah. Can I ask, for a hip replacement surgery, what do they need to give up after surgery? For example, people say that if you replace your knee, you may not be able to run again. You may not be able to do a full squat. Is there something similar for the hip replacement?
I think the result of hip replacement is really good. Actually, a lot of patients have it's very good for pain control. But to answer your question, they have to give up squatting. They cannot do deep squat because of the risk and the fear of dislocation.
Why
the hip dislocation? Because when we do a hip replacement, the native hip joint, the original hip joint is very stable. The head is very big. So I mean, it's a biomechanical understanding of the hip joint. So the head is very big. There's a very low chance for it to pop out. But when we do a hip replacement, in general, the head is smaller. So if the head is smaller, you need a smaller excursion for the hip joint to dislocate.
I get what you mean. It's like a ball and a socket.
Yes, a big ball versus a
tiny
small
ball.
Yes,
it's gonna slide out.
But the risk is in general very low, 1% or lower. Okay.
Can they run after? Wow.
I would say they can run.
I'm just curious, why not make the ball bigger?
It's again a understanding of the wear and tear. So when the ball is bigger, there's a more wear-related issue. So there's more surface area, there's more, So it's really like you say, it's a trade-off. We can choose different size for the ball, 28, 32, 36 mm. Okay, it really also depends on the size of the patient. So there's many factors involved, and we will make the decision during the surgery.
So you say that someone, you're saying like a more elderly person who's having quite a lot of hip pain and they like to run. So technically, if after doing a hip replacement, they would have much less pain and they can potentially go back to running.
But you see, I will always say that it's a lifestyle decision. I will always discuss with the patient, okay? More running means more wear and tear, more loading on the implant and higher chance of failure and revision later. So it's a decision that we make together. It's an informed decision. Of course, after the hip replacement, if you don't if you lead a sedentary lifestyle, then that may defeat the purpose of doing a hip replacement.
Right.
Because certain individuals may do a hip replacement to be able to achieve certain lifestyle, to want to go back to a certain lifestyle.
Golf. Yeah.
Golf,
Yes.
the golf definitely is a low impact because a lot of use a buggy or they walk on the grass patch, so golf shouldn't be an issue. But running per se maybe is considered higher. Maybe they have to reduce the mileage, right? Maybe they have to reduce the speed, but they can still do it. They can still enjoy the
Less
ride.
pain.
Yeah. I think nowadays a lot of patients they're asking about quality of life, and they definitely want to go on holidays. A lot of them want to go on holidays, and that shouldn't be an issue.
Okay, so really, if you're looking for if you're just going to be purely sedentary, there's almost no point in going for surgery because you're just going to be sitting down.
But for pain control, even for the yes, exactly. Even for the sedentary patient, I mean, sometimes they reach the level where going to the market, going for meals is already painful. Very common.
They're on the mobility devices.
Yeah, exactly.
Yes.
All because of the pain. Right, and so by doing that surgery, then they're no longer in pain. Then
Yes.
you actually just allow them to do simple things like just walking out to buy food from like local hospitals.
Exactly. Activities of daily living is important as well. They don't want to be in pain every day.
I have a client currently with me now who's on a mobility device and she has hip pain as well and she's seen the doctor and the doctor said like, yeah, you need to eventually do a knee replacement.
Oh, no.
Until then you got to lose weight and give up certain habits. Yeah, but which is the hard part.
It's very difficult to lose it when you're
When you're
knee
immobile.
pain.
Yes.
So I always say treating the joint pain, hip pain, knee pain is to get the patient healthy in general. It's not just treating the knee or the hip. Because if you have a knee pain, hip pain, you're on a mobility device or you cannot exercise, it's very difficult to lose weight. It's a vicious cycle.
Yeah, it's pain, so you don't exercise. You put on weight, and then it gets even worse.
Yes, and your joints get weaker. You put on weight.
It's a spiral in itself. Then they should get surgery done. And speaking of surgery, what happens during a hip replacement? Do you like take out my entire hip? Is it just changing a small component, or like what are the different variations of hip replacements out there?
So if you talk about hip osteoarthritis, in general, we do total hip replacement. So the hip joint is made out of the cup and again the spherical femoral head. So in the total hip, we replace both. Okay, so we will shave off. There's a reamer where we can shave off the cup and then we can put a metallic cup inside there. Okay, for the femur side, we will excise the head and then we can put a metallic stem inside there. And the ball is made out of either ceramic or a metal. And the metal cup has a polyethylene liner. This is a plastic liner. So that allows articulation. Okay, this is a total hip replacement. Okay, I mean there's a half hip replacement, for example, some hip fracture, hip fracture where the cup is still healthy, we just replace this part. Okay, so this is a hemi-arthroplasty. So we replace half the hip joint.
Hemi-arthroplasty, half.
Hemi, yes, correct. Yeah, right there. But for hip osteoarthritis, we're talking about a total hip replacement.
So total hip replacement, you're replacing both the ball and the socket as well.
Yes, ball and the socket.
And then and that usually happens for like degenerative conditions, like you mentioned. But if someone comes in because of a fracture, then you would just replace the
fracture component.
The fracture component, which is usually just like the ball.
Yes, the ball.
I'm curious, when would you replace it with like a metal ball, and when would you just like fix the current bone? Because if it's a fracture, I'm guessing you can like join it back together. I'm not an expert, so I'm not sure as well.
So there's a lot of details in this. Okay, so but in general, if the fracture is displaced, we will replace it, because when it's displaced, we believe the blood supply is compromised. So even if we fix it back to its original position, the head may die off eventually.
Then you have to go in again.
Yes, exactly. So we just replace it. Yeah, and at their age, in general, these are the older patients. These are the older patients. So we'll just replace it already.
Whereas like if you fracture your
like a radius ulna. There's no way to replace, so we'll just fix it. Okay, and that's because of the blood supply is very good. So the hip joint has a very special blood supply where it goes this way. So when you have a fracture, the blood supply from that direction will be compromised.
Cut off.
Yeah.
Right. Whereas like for most other parts,
there's a few supply points. Yeah.
Right. And then it will recover on its own. Okay.
So we rather replace it in the first setting rather than doing a fixation, wait for a few months or 1 to 2 years, it start to have avascular necrosis and it collapses. Then we need to do a second surgery.
And you're sharing that this kind of population is usually the older folks who have a fracture, then you replace. And does the fracture usually come in because of falls, or is it like more traumatic, like an accident?
Just as fall. Actually, most of them is just a fall, and because they're osteoporotic.
Oh.
Yeah, so a simple fall, getting out of the toilet, tripping on the curb, and then they land on the floor, and then it may result in a fracture already.
Oh, so usually it's elderly. Usually it's the
Elderly
who end up falling down.
Yes, because they are higher risk of osteoporosis.
Right.
So we always say osteoporosis is a silent disease until it presents as a fracture. So we always try to screen and treat osteoporosis.
Okay. And can I ask about fracture? Like, because my understanding is also if a bone is fractured, then we put it on a cast and it can kind of self-heal to most extent. Can that happen for the hip in this population?
In general, in a joint, we cannot immobilize the joint. So the closer the fracture is to a joint, the more difficult it is to immobilize. Because it's too mobile. Example, if the fracture is here, it's relatively easy to immobilize. But let's say the fracture is near here, it is quite difficult. We can put a cast over the whole elbow, but there will still be some movement inside there. So in general, it's almost impossible to, at least for the hip joint, there's no such thing as a casting for the hip joint.
Okay, so almost the only solution is to change the hip joint in these scenarios. Okay.
Yes. Or if it's undisplaced, we'll put in some screws to fix it.
That's interesting. And in your practice, I'm just curious, you mentioned it's 20-1, but within your practice, I'm just curious, is it mainly total hip replacements or like you say hemiarthroplasty?
Mainly total hip replacement, I said.
Because most of it is degenerative.
Degenerative.
So let's say someone does go for surgery, maybe let's say someone in their 60s, they do go for surgery, get it replaced. Let's say someone wants to be able to travel. I think that's very common. I think in their 60s, most people will still be very happy if they could head over to Japan and see the cherry blossoms. So then I'm guessing after that, you're going to be shifted over to Bala. So let's say that's the profile. Let's say I'm someone in my 60s. I am not too active before this. And then I had a very bad hip OA. Nothing was working. I just got it replaced. And my goal is to be able to walk easily. Maybe do light hikes. So I can travel, because there's some places that I want to hit to, some mountains that I just want to climb, or maybe not a huge mountain, just a little small hill that I want to see. How do I achieve that?
So post hip replacement, so actually the current research supports more of an unsupervised rehab program. So you can do it online, if you get in touch with a physio, they can put you through a program, because the outcomes are actually very good post hip replacement. So you don't need such a long supervised multiple sessions to get you back to pre-levels. But of course, if you have a certain goal that you have, which you never met before this surgery because of the pain and so on, then there will be this thing called muscle atrophy, where there's weakening of muscles around the hip. And that's where the physios come in to, one, strengthen these isolated muscle groups, and then put it into a more functional pattern, such as maybe stepping up, stepping down, climbing stairs, squatting to allowed limits, and strengthening these parts and also improving their cardiovascular, because likely if they were in quite a bit of pain prior, every system in the body is just not ready for a hike. So that's where the physio comes in with a bit more supervised sessions. So for this subgroup of people, but in general, I think most people can get away with simple exercises which are taught after the operation within the hospital setting itself, and maybe having online consults or just 1 or 2 sessions post as well.
Well, that sounds pretty good. That sounds pretty nice compared to maybe a ACL repair.
It's a whole different ballgame.
It's a whole different ballgame. Okay, but let's say I really do want to train up to go for the hike. I still want to see you. How long do I have to wait for? Will it be done?
Depends on my appointment slots. No, kidding.
It's always full.
How long do you need to wait to...
Before I can get to my goal, which is in this case, to be able to go on a short hike? Will it be, like 2 weeks? Or will it usually take maybe like 5 months, 6 months? Because I know for ACL, it does take maybe like 5-6 months just to hit like a certain milestones, and sometimes up to a year as well.
Yes.
So what about hip replacements? What's like a timeline that I can look forward to?
Yep. So I think a lot of it's going to depend on how you were pre-surgery. So whether you were active enough to even be possibly getting back to those type of levels. But in general, I think Dr. Lim can correct me as well. During the surgery, they do cut through certain hip muscles.
Muscle, yes.
Yeah, to access the joints. So these are the ones that, again, there'll be some precautions post surgery which we need to adhere to for a couple of weeks. Then, only then can we start training up these same muscles that have been cut through to strengthen them. And once that is sorted, then we got to put them through a bit more of the functional one assessments to the movement pattern itself to strengthen. And any kind of strength training program takes about 8 to 12 weeks to mature. If you were to, like, say I want to get into bodybuilding, want to grow big biceps, you got to put yourself through 8 to 12 weeks. So that's the rough, very conservative time frame I would say you should give yourself to go through the rehab and the strength and conditioning to be able to achieve your goals.
Right, because it's not just the surgery itself, because there is a cut and then it will take time for my muscles itself to heal as well.
Yes.
So even though we've replaced the bone, we need time for the muscles to heal. It takes about maybe 8 to 12 weeks, and we should give ourselves ample time for that.
Yes.
Hey, cool. I guess that kind of, it does sound like it is a lot better than ACL. So it's interesting for me to hear that. I do hope that I will never have to go for knee surgeries. But yeah, I think that also kind of wraps it up. Thanks so much for sharing a little bit more about hip replacement and also like the timeline. I think it does help me learn a little bit more about it. I do have a friend, a close friend whose mom actually just went for a hip replacement surgery recently as well. It was due to it's degenerative, so a total hip replacement. It was showing us I think it was an X-ray or MRI, and you can see the entire head was almost flat.
Yes, correct.
She was in a lot of pain. So I was actually really looking forward to this episode because I get to hear a little bit more about what goes on behind the scenes as well. So thanks so much for sharing.
And one of the important things I just want to clarify for the audience is that a lot of patients will ask me, how long do I need to be bed bound after surgery? And the answer is there's no need to be bed bound after the surgery.
Yes.
Actually, on the same day, we will get you walking. Okay, let's say, example, we do the surgery in the morning. By late afternoon, after you have taken some food, some drink, you're awake and alert, we will get the physiotherapist to start you walking on the actual day. Okay, because by walking early, it reduces the complication and the risk of surgery, which is like deep vein thrombosis, pneumonia. So walking early is really important. Okay, I just want to clarify this myth that needs to be bed bound. Okay.
And I got one very common question people ask me as well. How long will this implant last?
Oh my God, this is really, really real, man. Okay, so according to the biggest joint registry in UK, with more than 1.6 million implants inside the hip joint, they have been tracking them for 20 years. So the revision rate at 20 years is about, I think, 8%. 8%. So in other words, 92% of the joints survive up to 20 years.
Wow, that's very long. And I'm guessing most people will only get the replacements very late in their life.
Example 50s, 60s. Yeah. So the big majority will still be intact in 20 years. So that is a very common question. Okay, whether I need to be bed bound and how long will it last? Okay, so these are the two most common questions. I think one of the most is whether is it very painful. I think hip joint, unlike knee surgery, hip joint relatively less pain. I feel that they have a lot less pain than the knee joint, maybe because they are deeper inside, so they really have less pain. So the rehabilitation process, like what Bala said, is really a bit easier. It's a lot easier.
I didn't know about the hip being less pain. I would assume it's more painful because it's like a bigger joint. So it's just in my head it would be quite painful. But now that you mentioned it, my friend's mom didn't complain about the after.
Did she walk early? She walked pretty early, right?
Same day.
She got back. Yeah, she was walking pretty early. She does live a relatively sedentary lifestyle, but she doesn't even have like a weird gait. She's walking pretty much.
Actually, the surgery will correct the gait, the Trendelenburg gait. Actually, when they have hip pain, they tend to swing the body a lot when they have hip issue. So after the surgery, most of the time it can be resolved with the help of physiotherapy.
Yeah, and so they're likely not. Sorry.
I always recommend them for gait training with the physiotherapist because a lot of time the issue has been settled, but it's the habit.
Oh yes.
Because they've been doing it for years.
Right. Because when your left hip is painful, you naturally put more weight on your right.
Yeah.
You have that weird.
Yes, correct. So, and even if the pain has been more or less like addressed by the surgery, they still do it.
Yes, I have a client who did a limb lengthening surgery where they break the femur bone and they elongate it.
Oh.
Yeah, and she has a multiple revisions of that to further extend it. So she has been walking in this like very abnormal walking pattern for the longest time, right? And now she's kind of fully fixed, doesn't need to elongate anymore. She still reverses back to like a previous way of walking. So actually all the sessions are just me correcting the walking pattern, strengthening the glute medius and so on.
That's why I say physio is very important to get the best out of the surgery. So I always emphasize to be compliant for physiotherapy because the surgery is done. I've did my work, the patient has already did the work. So now it's for the physiotherapist to chip in. I feel it's a pity if we go through the surgery but we don't maximize the benefit. Okay, like this gait issue, I have a big mirror in my clinic. So when the patient look at herself and when she walk, it's gone. The gait become normal. So it is a habit issue. Then I send them
it's like
to
breaking the glass, you know, oh, I know I see it.
yeah,
I can't unsee it.
okay. So I send it to the physio and let them.
So for the closing, can both of you give one piece of advice for someone who just found out that they or a loved one may need to get a hip replacement? Let's just say really, really bad degenerative osteoarthritis.
Or from my perspective, I think the main advice is to start on some form of physiotherapy. Yeah, if you're already considering going for a hip replacement, because the outcomes, the stronger and more mobile you are prior to that surgery, the chances of you getting back to pre-levels or having a good outcome is going to be higher. So some mobility work, allowed range with less pain as possible, and strengthening the hip muscles would put you in a better spot post-surgery.
Okay, so physiotherapy before and strengthening before and of course after.
Yes.
Dr. Lim, what about you?
I think my advice is about the same as Bala. I think if there's really a lot of pain, a lot of hip arthritis, I think that my advice is do it earlier rather than later. Because the longer you wait, the more difficult that will be the surgery. When the hip joint becomes very stiff, it's very difficult for us to dislocate the hip and do the surgery. There's a lot of fibrosis, a lot of scarring around the hip joint, and that may complicate the surgery. And moreover, while waiting, there'll be a lot of muscle atrophy because when they're in pain, they tend to move less. And with the muscle atrophy, the recovery process will be longer. So if you need it, if I may say, if the risk is well managed, do it early rather than later.
Okay, so exercise before and after. And hey, if you're going to have to go for it, always do it earlier rather than later. Nice. All right, thank you both so much. I think this was a very interesting episode. I get to learn a lot about the hips. I think it's also because I don't get to see many people who do go for hip surgeries. So this is a very interesting episode, and it's helps me learn a lot as well. So thank you so much.
Thank you. Thank you.
Thank you
for
so